I'll start off by introducing our first speaker. This is Dr. Meg Haney, who is the professor of neurobiology at the Department of Psychiatry at Columbia University. Dr. Haney, I'll welcome you to the podium.
Thank you. And like everyone else, I'm so pleased to be here. And, I think this title was given to me as a placeholder, probably by Steve. And I decided to keep it because it's actually been delightful to dig in and go back and remind myself of how foundational behavioral pharmacology has been for me. Obviously, I was trained by Klaus Mitschek and Marion Fishman, both from University of Chicago, which has not been mentioned. We've had a lot of Hopkins and we've had Minnesota, but University of Chicago was also pretty important. So I am so happy to go back and really think through again about behavioral pharmacology because I don't think it's a phrase we hear a lot anymore. It feels out of fashion, or, I just want to kind of, wave the flag again about behavioral pharmacology. And again, it is just been foundational to everything I've ever done. Oops, I skipped my conflicts. I advise a little bit, but it has no bearing on this talk. So, again, in thinking about behavioral pharmacology, I just want to, again, reinforce how critical it is from theory to practice. So I'm going to talk a little bit about how it drives my thoughts about theory and practice, in terms of medications development for cannabis use disorder. But, when you think about behavioral pharmacology, so it's drug effects on behavior under controlled conditions. Who are you studying? So anyone who's been to any conference with me knows I'm the crank that stands in the back of every neuroimaging talk and asks, so there, if somebody's talking about the neurobiological consequences of cannabis use, the question is, who are you studying? So when did they last use cannabis? You're talking about cannabis users. They might have used this morning, or they might have used 3 months ago. They're still classified as cannabis users. And it's critical to the endpoint. So I'm always raising my hand, asking that question. When was, who are you studying, and when was the drug last used? Which drugs are on board? For years and years, tobacco was just totally ignored, but every person studying people who use drugs, tobacco was part of the equation, but it was totally ignored when you're looking at the neurobiological consequences of the drug you happen to be interested in. When the drug was given, how much drug was given, dose. And you can't believe how much time I have to spend talking about placebo comparison and the importance of it, because when you study cannabis, there's the therapeutic potential of cannabis, and everybody's grandmother and aunt and dog is using some form of cannabis or cannabidiol, and they all say to me, but it works. And I'm like, that's fantastic for you and your dog and your aunt, but that's not public policy, and that doesn't prove to me that it's a medication. So believe me, I spent a lot of time defending the scientific method when it comes to cannabis. So I'm going to talk about cannabis administration, subjective effects, reinforcing effects, and behavioral specificity, and then talk a little bit about tolerance as well. So again, who is getting cannabis, or who is getting the drug, which, when, how much, and placebo control. So as many of you who have seen me speak, they've seen this slide 1,000 times. So this is our residential laboratory. This came out of the Joe Brady's lab. So he really designed, and it's not something I talk about a lot, but the residential lab that Marion took from Hopkins to Columbia, Marion Fishman, the design of it was really to minimize the investigators' interaction with the participants. So we really we bring in 4 people at a time, non-treatment seeking cannabis users. They live in the lab, and most of our communication with them is through the computer. So it was very structured. Our communications were all formalized and characterized, because all the things we were interested in, mood and so forth, were going to be influenced by the personnel you were working with. And so I think Joe Brady originally designed this to take that factor out of the equation. So the people we are studying are non-treatment seeking daily cannabis volunteers. They have no major psychiatric diagnosis or other substance use disorders, except often tobacco. And that is a whole other talk, as tobacco is very important when you're looking at the interaction. I think Dustin's going to touch upon this right after me. So which, when, and how much? So we have this laboratory setting. Most of our studies are inpatient, so we can confirm the timing and the quantity of cannabis use and confirm that there's no other drug use on board. We administer both active and placebo cannabis. And behavioral specificity is something, our preclinical colleagues spend a lot of time thinking about. When you give a drug and a medication, for example, you want to really confirm that you're really focusing on the factors that are relevant to addiction, and your medication's not producing a lot of other effects that could confound your outcomes. So in this lab, we're measuring mood and drug effects. We're administering cannabis and medications. Typically, we're getting detailed information on sleep, food intake, drug craving, cognitive task performance, cannabis self-administration, and cardiovascular effects. So let's just jump into the subjective effects. So I'm just going to guide you through a lot of these figures. So on the y-axis is our ratings. A visual analog scale goes up to 100 is the maximum. And this study was looking at the acute effects of cannabidiol on the effects of cannabis. So this is inactive cannabis. And, our participants are daily 2 to 3 gram a day cannabis smokers who don't miss a day. They're very, very regular with their cannabis use. And even this group we see a placebo effect. So if the black is the placebo cannabidiol condition, and you see, a small but time-dependent increase in ratings of I feel high with inactive cannabis, even in this very experienced group. And instruction matters, so what we tell participants is we're going to have you smoke a controlled amount of cannabis, and we're not going to tell you the strength. The strength is going to vary from session to session. You tell us what it feels like, and that's the way we're going to do it. So we see this classic placebo response, and then when you give active cannabis, of course, it's significantly different from the placebo condition. This is approximately 23 milligrams of THC inhaled over 3 minutes, and you see the time course. So by 2 hours, the effect is largely gone. So now this is a much higher dose. So this is 67 milligrams of THC approximately inhaled over 6 minutes. And you can see much larger effects. So again, the maximum score you can get here is 100. And so again, same population of 2 to 3 gram a day people, cannabis smokers. So they're really maxing out almost on this graph of feel good cannabis effect, cannabis liking, and cannabis intoxication. So, on my tombstone, it's going to say the words potency is not dose when it comes to cannabis, because the potency we're testing is quite low. It's nitocannabis, it's 5 to 7% THC, but you got to work around that. So we give a controlled amount. It's a lot. We give a lot of this fairly weak cannabis. And so we can get a dose roughly of 23 milligrams of THC and 67 milligrams of THC. So dose dependency with cannabis is tricky because it's smoked. There's workarounds, but so we try to control exactly and time how much of an 800 milligram cigarette that they smoke to try to get a decent estimate. And so here it's, we're getting significant differences as a function of these doses. But, when we've tried to do dose dependency with different potencies of cannabis, the line is always flat, because if it's strong, they don't inhale as much. And if it's weak, they inhale more, even though you're trying to control for that. So that's the positive subjective effects. And here's where I'm going to touch upon the theory and how behavioral pharmacology informs this. So George Koop and Michel Lemoine published a paper in 2001, and then George Koop is continuing this story where he talks about hyperkatifia. And this is the opponent process theory. So you think it's best to think about alcohol. So, you can imagine you have a couple drinks, say 3 drinks on a Saturday night, and you get the A process, which is a positive mood state. And then you wake up the next morning and you are in a negative mood state, and you're significantly below your baseline mood state. So it's like there's no free lunch. You're going to have a great time and you're going to have a worse time the next day. And so their theory is disorder, but with repeated drug use, brain reward system shifts, and that now you're using a drug just to get over time, you're not experiencing that A state anymore, that positive mood state. You're simply using drug to get back to baseline. But as a person who's given drugs to people for many, many years, and not just cannabis, but cocaine as well, again, this is the population he's talking about. These are cannabis smokers, 7 days a week, 2 to 4 to 3.3 grams a day. They experience robust cannabis withdrawal when cannabis is taken away. So there's clearly, it's not simply negative reinforcement that's driving drug use. They still get a very, very strong positive subjective response to this. So, I've kind of raised this with the hyperkatifia crowd, and they don't seem to pay much attention to my point here, but it was the exact same when we would test the effects of smoked cocaine. These were people who were using cocaine for 25 to 30 years, 300 grams of cocaine a week. You give them cocaine in the lab and their mood was exceptionally good. So they certainly still do experience that. So I argue it's both for certain drugs of abuse anyway. So just to summarize the positive subjective effects story, so placebo control, essential, expectancy effect even among very, very experienced cannabis users. That you can achieve some level of dose dependence, and that potency is not dose. And in terms of hyperkatifia, daily cannabis smokers undergo significant cannabis withdrawal and have a positive subjective response to cannabis. So now to move on to positive and negative reinforcement more specifically. So positive reinforcement, you can think of self-administration under non-abstinent conditions is the way, I study it in the lab. Negative reinforcement is self-administration under abstinent conditions among very heavy cannabis smokers. And so we use a choice procedure where individuals in the lab purchase cannabis puffs, and they pay, the price is quite high. We did kind of the parametric studies to establish the dose that they never would pay, the cost they would never pay for cannabis, or the cost that they would buy it every single time. So we tried to find like a nice medium level choice condition. Oh, wow. Oh, dear. We tried to find a medium choice condition so that we could see if a medication would shift choice from drug to a non-drug reinforcer. It's their actual money, so it really matters to them, and then they're going to get it when they leave the lab, or they can just buy their cannabis. And so our working hypothesis is that shifting choice to a non-drug reinforcer in non-treatment seeking volunteers with cannabis use disorder is better at predicting an efficacious medication than other outcomes. So Marion Fishman was highly skeptical of subjective effects. She was pretty hardcore. It was just another verbal behavior to her. And so importantly, when you're looking for medications development, she started off with dizipramine and cocaine, in the early 90s. You can very easily dissociate subjective effects from actual drug taking. Shifting drug taking is really hard. Shifting how high or craving or other aspects of drug use is not so hard. You can find Medicaid, and that's what happened with dizipramine. Dizipramine decreased reports of I want cocaine, I'm willing to, I really want to take cocaine again, and those questions, yet it didn't shift behavior at all. So that's why it's been, and with cocaine, we've seen that 1,000 times. So we really stick to this as our working hypothesis. So in terms of cannabis, reducing positive reinforcement is another way for us we think of it as abstinence initiation. Can a medication decrease cannabis's positive subjective effects and reduce cannabis self-administration in non-abstinent individuals? Most people, or many people, show up to cannabis treatment, really want treatment for the cannabis use because it feels out of control for them, but many are not seeking to stop it. They're seeking to regain control of it, to go from a daily wake and bake to 2 to 3 times a week cannabis user. And it's a really important thing for those of us who do cannabis treatment research to really shift our thinking, because everything's about abstinence in our medication trials, and it's not what many people are asking for. So I'll just give an example of this medication that we tested. That's it acts at the CB1 receptor and kind of shifts the signaling of cannabis agonists. But what you see here, if again the open bars are the placebo condition, the light gray is the lower dose of the medication, and the the filled-in bars are the higher dose of the medication, you can see a very nice reduction in the acute effects of cannabis, something I haven't really seen before. So this was really a very exciting finding for us. So in parallel with it, so in designing this study, I did make a mistake. I'd given them 67 milligrams of inhaled THC is a pretty hefty dose, as you can see. And so, over the course of 105 minutes, it did not really abate very much. And yet I started self-administration at 2 hours and they had no need to self-administer cannabis. So, in hindsight, I should have waited a lot longer. But here's the self-administration data where, again, you could see over time of the day, typically as the evening goes on, people really want to self-administer cannabis, and this medication at the higher dose did shift that response down. And this parallels the non-human primate data very nicely. It was Zuzana Justinova from Steve Goldberg's lab who has had monkeys who would self-administer THC, and she found that similarly, it took the higher dose for that behavior to shift, where lower doses would shift reinstatement, but the higher dose was needed to actually change drug taking. So that's just an example of reducing the positive reinforcing effects of cannabis. Much of my work has been to reduce the negative reinforcing effects of cannabis. So can we decrease cannabis withdrawal symptoms and a return to cannabis administration following a period of abstinence? And this is more like a relapse prevention model. And so, it was back in the 90s where we, and certainly Alan Budney did a ton of this work too, but really characterizing cannabis withdrawal. And there is a time course and there is, varying severity across all of these symptoms, but it's characterized by increased anxiety, irritability, depressed mood, restlessness, marked decrease in food intake. That recovers quite quickly, but sleep is disrupted from the beginning and stays disrupted for quite a while. And it certainly contributes to the maintenance of daily cannabis use. And so, just the way the studies work is participants move into the lab for 8 days on various occasions, and they're maintained on medication in one of those phases and placebo on the other. First day, they get active cannabis repeatedly. They then go through 3 days of abstinence. They can self-administer placebo if they want to pay for it, and some do, but regardless, we're capturing withdrawal. And then there's 4 days in which active cannabis is available, and that's our model of relapse. And they're paying, as I said, it's $9 for the first puff of the day and $2 for subsequent puffs, so it's expensive. And so we've tested a lot of medications, and I'll just kind of walk you through the one I always talk about, which is nabilone, which is a very long-acting CB1 agonist. And this figure just shows their first bar is when they're getting cannabis, and then the remaining bars are the different doses of nabilone. So you see under placebo conditions, there's an increase in irritability, and that both active doses of nabilone reduce that. Participants were not getting intoxicated with these doses of nabilone. It's very, very slow onset and long acting. And it just really mitigated the effects of withdrawal on many sleep measures, food intake, and this is our measure of relapse. So those 4 days that participants could relapse to cannabis. The first day, there was a significant effect of nabilone, but people were sampling a bit. And then by days 2 to 4, nabilone really nicely reduced cannabis self-administration. So in terms of behavioral specificity, the question is, does a medication reduce a drug's reinforcing and positive subjective effects without changing behaviors unrelated to a misuse liability? And it's really critical for understanding the precise mechanism of drug action and for developing targeted therapies with minimal side effects. And the focus of our lab is really to get a good signal with a medication in a small N to then potentially move it to the clinic. And so I just wanted to describe, this one study where we were looking at the effects of lofexidine, this alpha-2 receptor agonist, because I think like opioids, there's this noradrenergic hyperactivity during cannabis withdrawal. And so we gave lofexidine alone, we gave dronabinol, which is just oral THC alone, and we were trying a higher dose than we had shown before to very nicely attenuate withdrawal. And then we gave the combination to see if these two different mechanisms might be the best answer. And so, so what you see going across the x-axis is it's placebo, THC alone, lofexidine alone, and then the combination. And so we see a significant decrease in craving. THC alone, participants reported wanting to take again, but the combination, they did not. We see, again, a nice attenuation of sleep. So sleep latency goes down, and they're more satisfied with their sleep when you have the combination. And again, most importantly, when you look at self-administration, THC had no effect. Lofexidine alone did decrease self-administration, but the combination really worked very nicely. So this led us to support moving it to the next step, which is a clinical trial, which is the gold standard. And so that's what Francis Levin in our division has done more than anyone, a randomized controlled clinical trial. This was 156 cannabis-dependent participants in an 11-week study, and efficacy was designed as a 3 weeks of abstinence at the end of the study. And so, she gave the same dose of dronabinol, but a lower dose of lofexidine because these were people out in the world, and we were worried a little bit about blood pressure. So, so what she found was no medication effect. So placebo, it's actually a pretty nice response. 29% could demonstrate 3 weeks of abstinence in the placebo group, and the dronabinol and lofexidine group, it was shorter. So a significant number of participants did not achieve the target dose, even though it was lower than the human lab, and it was largely due to fatigue. So that led us to kind of go back and really look at our data again. And, something I didn't pay a ton of attention to at the time was lofexidine alone and the combination really produced pretty profound sedation. 50 for me is a very high dose of sedation. And I didn't pay attention because our participants didn't care so much about that sedation. They were living in the residential lab. They were playing video games, watching movies, doing a few cognitive tasks, and they were loving life. And so nobody complained about the sedation, but the patients did. So just to quickly summarize this, the positive reinforcing effects, AEF 0117 worked the best, Nabilone worked the best for negative reinforcement. And really, I'm always modifying my model to try to improve upon it to better predict, something that might work effectively in the clinic. And so this is a Klaus term, is the constellation of behavioral effects in a controlled setting. So you're really looking at all of it to really see, what's going to be tolerated and work in the lab. I'm just quickly go through tolerance because it's something I really find extremely interesting, but I don't have much time. But Jill Betty a while ago in our lab was looking at dronabinol in HIV. It's approved for HIV-related anorexia at very low doses, but cannabis smokers, we show, need a lot more dronabinol to have any effects. So nobody had really looked at that. So here we were giving 10 mgs 4 times a day versus placebo. People lived in the lab for 16 days on 2 occasions. And we wanted to really look at tolerance development. And so what you see at the top is the clinically relevant outcome, which was daily caloric intake, because our participants, complained a lot about digestion. At the time, the HIV meds were really tough to tolerate. And so you see in the first 8 days, we see a really lovely increase in caloric intake in the open bars, but that by 8 days no longer had that effect. Yet there's positive subjective effects to dronabinol. There was no shift in that over the time period. And this is, I think, really clinically relevant for a lot of different therapeutic implications. Differential tolerance development. If your therapeutic effect is you're developing tolerance, yet the abuse-related effect you're not, people will start upping their doses. There's a very high incidence of cannabis use disorder in people who use cannabis therapeutically, and it's because they're using it repeatedly and potentially developing tolerance to the clinical outcome, but not to their, not to the abuse-related effects. I know I'm running out of time. So anyway, long story short, Ziva Cooper did a study showing that cannabis and dronabinol both had these analgesic effects, and cannabis alone really increased the misuse-related effects, how high and good drug effect. And, pain, but what we don't know is what happens with repeated administration. What happens to the analgesic effects with repeated administration? Tolerance is one of the most commonly endorsed CUD symptoms, and pain is the most common physical health reason for medical cannabis use. What happens with repeated use? Again, does that analgesic effect attenuate over time, yet the high and the good drug effect persist? And how does that change long-term use? I'm just going to skip through that, but medical cannabis is really a risk factor. So I'll just describe this one more data slide, because this is Carolina Root, who's an assistant professor in the lab, and she did a really, really hard and very important study. This is just preliminary data, where she brought people into the lab for 16 days. First day they got active cannabis, and then they went 8 days of placebo cannabis only, and then 8 days of active cannabis. And we're looking at both pain and misuse potential. This is a figure of pain tolerance. High means good analgesic effect. And it was a comparison to baseline on that first day. And what you see is, after this period of 8 days of abstinence, you give them cannabis again, there's an enormously more robust analgesic effect. But then you give them active cannabis again, and it very quickly goes away. So you lose tolerance quickly, and you regain it very quickly for pain for this analgesic measurement. For ratings of high, similarly, we see this very robust enhancement when you give active cannabis following 8 days of placebo, and tolerance does develop. It doesn't seem to develop quite to the same degree as quickly as it did for pain. So we're pursuing this in a much larger study, but tolerance to both analgesic and intoxication are quickly lost and quickly regained. And so we do have an upcoming study to really pursue this more and to really look at the different chemovars. Because medical cannabis consumers, 95% prefer a THC CBD combination. That could just be marketing. That's, there's the halo effect around CBD. There's a lot of reasons for that. Cannabis experienced patients want more THC content, and yet with repeated use, novice users also seek higher THC content. So there's a lot of that asks a lot of questions. Is the higher THC more efficacious for pain? Does tolerance develop to the therapeutic or abuse-related effects? There's a lot of things we still need to sort out about these different chemovars given repeatedly. All right, good, I made it, okay. So controlled studies on cannabis are needed to address clinically relevant issues of misuse liability, therapeutic effect with chronic administration, and the principles of behavioral pharmacology are essential: dose, constituents, time course, placebo, tolerance and withdrawal. And without careful control of who, what, when, and what do neurobiological measurements mean? There's so many sophisticated, measurements right now, but kind of without behavior, who cares? So that's also my cranky response at every conference I go to. So thank you very much.
Thank you, Dr. Haney. I'll introduce our next speaker. We'll save questions for the end, as we have been over the past day. Up next, Dustin Lee will be presenting on evaluating the behavioral pharmacology of cannabis and tobacco co-use. Dr. Lee is an associate professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins. Dr. Lee.
All right. Thanks, everyone. I want to start out first by thanking Steve and everyone at VCBH who puts on this conference. I've been coming here almost every year since 2013, and I'd say just about every year I walk away thinking, man, that was the best 2 days of science I've spent. I mean, just the platform to foster this like intellectual discussion, this creativity is unmatched. So thank you, Steve. Really appreciate it. So without further ado, I'll get in. I have no disclosures other than we received grant support from NIDA to conduct our trials. And that is a picture from the Joe Brady building at VPRU looking over downtown Baltimore. Elise Weirtz and I have a competition in the fall season over who can collect the best photograph of a sunset in Baltimore. And I think I'm the reigning champ. So let's get into it. Cannabis and tobacco co-use. I'm going to preface this talk by just noting that this is an in-process talk, not an in-process talk, it's an in-process area in cannabis research. So like a lot of cannabis talks, we're going to come out with more questions than we do answers. But that's kind of the purpose of this today, hopefully, if I do my job right. So what we do know is that tobacco use is highly prevalent among cannabis users. Just about 70% of past month cannabis users also report using tobacco. This is kind of old data, but I like it because it demonstrates the consistency of cannabis and tobacco co-use across the years. Looking forward a little bit to a little bit more recent data. Here's data from the National Institute on, or the National Survey on Drug Use and Health. And I think the interesting component here is, first of all, to look at the overall decrease in tobacco use, which was noted a lot yesterday. But on the other end of the spectrum, we're seeing upticks in both exclusive cannabis use and cannabis and tobacco co-use. So this is presenting a potential new avenue toward tobacco use disorder in a vulnerable population. So we know that there are many potential common neurobiological and behavioral mechanisms that may underlie co-use, including common and reciprocal genetic pathways of co-use, pharmacological interactions between the two endocannabinoid nicotine systems, and a common route of administration where both substances are typically inhaled either via smoking or by vaporization more recently. And they're used together, co-administered with blunts and spliffs or chasing, which I'll get into a little bit in this talk. So this common route of administration may result in increased learned associations between the two drugs. So creating conditioned smoking cues, signaling the availability of reinforcement from the other substance, and resulting in negative impact on breaking the pattern of co-use. So I'm going to redirect for a second to talk about treatment. I know this is human behavioral pharmacology, but I want to talk about my origin story in this topic area. So we know that tobacco negatively impacts cannabis quit rates. Tobacco users have higher levels of cannabis use disorder, lower rates of overall abstinence in adults, and increased likelihood of relapse in adolescents. We also know that cannabis use among tobacco users predicts continued long-term tobacco use. So my postdoctoral mentor, Alan Budney, who's not here today, I think he's decided that watching Penn State was more important. I disagree this year, but that's not for me. So I started my postdoc with Alan in 2013, right when he was beginning to look at avenues to improve his behavioral intervention for cannabis use disorder. He had developed behavioral intervention working with Steve, consisting of contingency management, cognitive behavioral therapy, and motivational enhancement therapy for cannabis use disorder. It was fairly successful. I think it's still the most effective behavioral intervention out there for cannabis use disorder. But we still had a pretty low ceiling on long-term abstinence rates, that notwithstanding the reduction debate that's currently ongoing. At this time, long-term abstinence was the key outcome. So Alan was interested in looking at different approaches to add an adjunct treatment for cannabis use that might improve abstinence rates. So tobacco was the low-hanging fruit here. In Alan's previous cannabis trial, he found that unpublished data found that over 50%, so about 60% of tobacco smokers entering treatment reported some interest in quitting tobacco. So we thought, hey, this is a good target. And we started a randomized controlled trial, which I conducted my whole time with him and a little bit after. And I want to quickly shout out John Hughes with this. John Hughes was integral in helping to develop the tobacco intervention for this trial. But that was the least of what he did. What he also did was help guide us through the whole trial of what turned out to be a very challenging trial, which I'll get into in the rationale for kind of the whole career progression I've had looking at cannabis tobacco co-use. So John's reflection on individual level differences in cannabis use, and especially his naturalistic studies that he was doing in mid-2010s, looking at day-by-day quit attempts in both tobacco and cannabis, were integral in us kind of figuring out some clarity with this clinical trial that we had ongoing. So I won't belabor too much on the actual study because I don't have time today, but I do want to talk about the outcomes. So overall, we had a 12, so let me just explain a little bit. We had a 12-week trial. We were looking at Allen's CBT, MET, CM trial paired with a tobacco intervention that included tobacco education modules and NRT. It was all optional. People could take part in it, not take part in it. It was up to them. And we tested either simultaneous approach to treatment or sequential, meaning that they would get both tobacco and cannabis interventions at the same time, or we would stack them. What we found was, regardless of treatment condition, we found lower abstinence than previous trials, cannabis abstinence. And we think that's because we were recruiting one of the most challenging groups of individuals with cannabis use disorder who are co-using tobacco. We didn't find any significant differences in applying the tobacco treatment in either sequential or simultaneous. We did find that there was a lot of interest and a lot of participation in the tobacco intervention, and even people who were assigned to the sequential treatment ended up quitting on their own during the simultaneous or during the first 12 weeks of cannabis. So we found some like self-monitoring was helpful, just alone of like asking people, are you still using tobacco? What do you look like? Did you make a quit attempt? But overall tobacco abstinence rates were low and there were no group differences. What are the outcomes from this trial that really took a while to distill was the heterogeneity in tobacco use in this population. So we had individuals that came in that were using blunts only, all the way up to people who are using a pack or more a day of tobacco. So it's really hard to kind of create a one-size-fits-all tobacco treatment for this population. It's very heterogeneous. So the key coming out, one of the keys coming out of this trial was to look at, or to really drill down to patterns of tobacco and cannabis co-use. And as a behavioral pharmacologist trained by Tom Kelly at Kentucky, that kind of drove my interest in bringing in co-use into the lab environment. But before I get into that, just to really drive home the heterogeneity in cannabis and tobacco co-use. This is, I think, a really eloquent figure from Danielle Smith's group at Roswell Park, who looked at wave 7 of the PATH data, and they looked at patterns or product combinations of tobacco and cannabis used. And if you look down the first column, I think the key highlight there is that we start with older adults, move down to younger adults. And so what we're seeing is that cigarettes and smoked cannabis are most prevalent in the older adults. You move down and e-cigarettes, vaping become most prevalent. After that, things become pretty wild. And in fact, what they found was between 300 and 400 unique cannabis and tobacco product combinations in the PATH data set across adults. I didn't even know there were that many products in reality. I guess so. But it's pretty intimidating. It makes my palms sweaty as a laboratory scientist. But we have to start somewhere. I think probably the most reasonable place to start, instead of looking at all these different product characteristics, we can include them, but we need to really pay attention to temporal proximity. So historically, when we're talking about co-use is an umbrella term. It's like impulsivity, right? Once you try to define co-use, it doesn't mean a lot. Most epidemiological studies will say co-use is past month use of either substance or both substances. But that doesn't say anything about how people are actually using these substances, right? So this figure, I think, is really eloquent. It's from Nguyen et al., Pamela Ling's group at UCSF, and really demonstrates the differential patterns of use by temporal proximity. And as behavioral pharmacologists, we're moving more to the right end of that spectrum, toward the overlapping effects of looking at both sequential administration, which is either tobacco or cannabis first, followed by the other drug. Generally, it's cannabis first, followed closely by tobacco, and then co-administration, which is blunts or spliffs. What we chose to focus on for this, we felt it was a good model for the behavioral pharmacology lab to look at both the separate and combined effects of cannabis and tobacco, is to look at a sequential approach. So individuals in this was a qualitative study. So individuals in this study reported chasing for these various reasons of seeking combined effects, enhanced euphoria, all these things we can measure in the lab. That's great, we thought. So the first study that I'll talk about briefly was an R33, and I think I have the wrong title on here, but it was an R33 that Ryan Vondre was a PI. Tori Spindle and Austin Zamaripa at Hopkins were also involved in this study, and it was an MPI grant with Jenny Wiley at RTI. And the purpose of this trial was or the human component of this, there was half preclinical, half clinical, was to examine how acute cannabis use affects subsequent tobacco and vape behavior, chasing under controlled lab conditions. So we recruited 20 adult users who use cannabis and also reported using both cigarettes and ends. This trial consisted of study consisted of 7 double-blind sessions. We administered either THC in either 10 or 25 milligrams versus placebo. Pause here for a second. We were looking for a very moderate dose of THC. So we started with 10 milligrams as the high dose, and then realized that we were getting a lot of frequent cannabis users into the study. We needed to bump up the dose a little bit because they were barely even feeling any effects at all. So we kind of stratified based upon frequency of cannabis use, either 10 or 25 milligrams. But the key was to administer a moderate dose of THC, so then we can look to see the boosting effects of tobacco or nicotine. Following that, there was a 5-hour ad lib access to either preferred cigarettes or Juul, 3% and 5% balanced across sessions. And one other side note and a spoiler, we provided them a preferred brand cigarette at baseline to standardize nicotine levels. We thought it was important to do that at the beginning of the study. Measures here, basically standard behavioral pharmacology outcomes. I'll go through a few of them here, but they were collected at various time points throughout the 5-hour session. And here's some data. So here's some subjective effects. This is field drug effect. It's the visual analog scale, peak change from baseline. The blue bars represent the active THC cannabis. The red bars are placebo cannabis. And each bar represents a different nicotine or cigarette condition. What we found here overall is the main effect of cannabis, and not really any effect of nicotine or tobacco condition. So participants felt the drug, felt cannabis more. Nicotine didn't really boost that in this study model. Same story for pleasant drug effect. And I put unpleasant drug effect on here just mostly to demonstrate that there isn't any effect across conditions. We're really looking at very little unpleasant effect, maybe a little tiny bump at the high dose of Juul. But overall, this kind of is evidence of the very moderate dose we were providing in this study of THC. Cognitive performance, again, didn't find much, no changes in psychomotor performance. It looks like there's a little bit of improvements on the pace at the preferred cigarette condition. Those weren't statistically significant, but still a tiny bit of improvement, which would be consistent with prior literature. I told you this is an in-process area of research, right? We also didn't find much in the way of behavior. So nicotine, tobacco, self-administration, most of the time people self-administered each product about 2 times during the 5-hour ad lib session. And they self-administered the first nicotine or tobacco condition about an hour after receiving cannabis. So bottom line, we didn't find much evidence of pharmacological chasing in this study, but there were a couple important caveats. I mean, the first I've kind of alluded to, we had a fairly low THC dose, so we might find, some differential effects with higher doses. So that's something that we're striving toward in the next study. And the other spoiler is that, again, going back to the heterogeneity of tobacco use in this group, we were recruiting people in that were pretty light smokers, usually about 3 cigarettes per day, maybe less, or in their dual use model, they might be less than daily. And so a cigarette's kind of a lot, right? Like they had to smoke a whole cigarette before they even, at baseline. So I think they were pretty satiated, which might have delayed self-administration in the trial. So lessons learned from that. Another lesson learned, controlled lab constraints present challenges for naturalistic co-use modeling. It also presents challenges for grant writing. It gives 2 targets for reviewers. Nonetheless, we persevere, and Justin Strickland and I wrote Neuro1 to look at the effect of cannabinoids on tobacco product demand and pharmacodynamics. The goal here is to determine the impact of acute THC administration, similar to the last study, but here we want to separate the products out a little bit more into combustible tobacco cigarettes and e-cigarettes. And we're running 2 separate studies here, 2 double-blind placebo-controlled within subject laboratory studies, just to set the stage here. We're like 10% into recruitment, so I'll be talking about the methods more than the result. I may have looked under the hood, and I may have a couple graphs to show, but don't hold me to that data. The target sample size here is 100 per study. We're at less than 10 per study. So just to set we just started year 2 of this. So I think we just started year 2. We're somewhere in year 2. General cannabis and tobacco inclusion criteria. We're looking for at least weekly cannabis use. In study 1, they're daily cigarette users. In study 2, they're daily e-cigarette users. The study drugs we're administering are placebo cannabis, 5 and 30 milligrams THC. In study 1, we provide spectrum cigarettes at either a very low nicotine strength or regular commercial grade strength, either menthol or regular, depending on their preference. In study 2, we're using the Views Alto e-cig at 1.8 or 5%. We had originally designed this study to look at or to use the Shrek, but due to ongoing litigation, the Shrek's not available. So we had to switch to some commercial brand. So we're really bummed because we don't have the placebo nicotine condition in here, but we're using the low strength versus high strength. Study drugs, we received cannabis plant material from NIDA Drug Supply. Again, thank you, NIDA. Participants are stratified to receive cannabis either vaporized or smoked administration. So we're looking for, in each study, we're stratifying 50% of cannabis users to smoked conditions, 50% to vape condition. The goal here is to look at congruent versus incongruent routes of administration for cannabis and tobacco to see if that matters. So if you smoke cannabis and vape tobacco, are there going to be different behavioral effects, different subjective effects, et cetera? And we used a paste puff procedure for cannabis and tobacco administration. So the session timeline here, we have 1 practice session, 6 laboratory sessions, testing each THC and nicotine yield. We start with a standardized puff instead of a whole cigarette. standardized nicotine levels. Nicotine or THC administration occurs about 15 minutes after we provide either the study cigarette or e-cigarette. They administer that in a paste puff procedure as well. And then we do an incentivized purchase task, after which, where they're able to purchase puffs. I'll talk about that on the next slide, but after which they have an ad lib period in which they're able to administer any puffs that they choose or they purchase during the task. At various time points, we're collecting subjective physiological outcomes. So the incentivized purchase task, participants in this task, I'm sure most of you know basically what this task involves, but participants input the number of cigarette or e-cig puffs that they want to purchase at one of 22 prices ranging from free all the way to $10 per puff. Participants can purchase puffs at each price point they're given a budget of $50. So they can purchase as much or as little as they want. Then participants select a random poker chip. Oh, and they're also told that they're going to receive the puffs that they purchase at one of the price points. So, for example, here I'm showing price per puff for a participant's choices. They chose to purchase 8 puffs at $1 per puff, and that condition was chosen. So, in our study, then they would have the chance to administer 8 puffs over the next 5 hours. Here's the data that you should take with a big grain of salt, because it's very early on. What we're showing here is basically across the board, across nicotine conditions, reduced nicotine content cigarettes have higher demand intensity, but it's more price sensitive. And it also looks like there's some blunted demand at the 5 milligram THC that recovers at 30 milligrams. But again, I think that's probably going to wash out over time. E-cigarette demand looks way more interesting, but again, we're very early on. But essentially, we're showing a stepwise increase in demand, especially at the 30 milligram dose. So hopefully that one sticks. So here's some future directions. I think the next step for us is to bring in simultaneous co-use into this approach. So we want to look at blunt use, spliff use. We want to co-administer cannabis or THC and nicotine at the same time, and start to unpack that, because that's another big subsample or subcomponent of co-use that has been relatively untouched. Ziva did a nice study back I can't remember how many years ago now, looking at blunt versus spliffs. Not many people bring tobacco and cannabis co-use into laboratory behavioral pharmacology environment. So lots of work to be done here. There's also lots of nuances in cannabis legalization that will probably be important for policy implementation. And the further intervention development's the ultimate goal for me, at least. So if nothing else, hopefully if you take anything home from this presentation, note that cannabis and tobacco co-use is extremely dynamic. It's a dynamic phenomenon. Likely multiple mechanisms contribute to co-use. And so, we need a lot of research here to unpack potential mechanisms. And if I can really get on my soapbox for a second, consensus terminology for co-use behavior is key. Aaron McClure published a great kind of a platform piece in the American Thoracic Society journal that really goes through in great detail all of the definitions, characteristics of co-use. I think that, she is leading the charge in really harmonizing terminology, but we really need to figure out as a scientific community how to harmonize this, how to actually study this dynamic process. And again, we need additional B-Pharm studies, and hopefully we can apply this to improve public health in the future. But anyway, thanks everyone. Appreciate your attention.
All right, I'll welcome our third and final speaker for this session, and of course, we'll save some time at the end for questions. Up next, Dr. Jacob Borodovsky will present on an epidemiological perspective on cannabis use measurement and self-titration. Dr. Borodovsky is a senior research scientist and epidemiologist at the Center for Technology and Behavioral Health at the Geisel School of Medicine at Dartmouth.
You pronounced my last name very well, so thank you. I do feel like a bit of a redheaded stepchild here because I'm an epidemiologist, not a behavioral pharmacologist. So I'm going to do my best to try to link the work that I've done to the work that you guys do, and you can tell me, all the ways I'm doing it wrong. So we'll get there. So thank you, Steve, and thank you everyone for coming. My name is Jake. I'm going to talk today a little bit about some of the work I've been doing, trying to look at population level measurement of cannabis consumption, and then show you a bit of a case study of how you can use the data and the instrument that we're developing to try to get at more fine-grained behavioral dynamics, related to the kind of work that you guys do in terms of self-administration behavior. So I don't have any disclosure or any conflicts of interest. That's important. Like I gave a talk for like a YouTube streaming podcast thing of like cannabis consumers, and these are all conflicts in their eyes. Like NIDA funding, not using cannabis currently, that's all conflicts to them. So I always put that on there. So I broke this talk out into two pieces. The first is I'm going to just talk a little bit about quantity, cannabis quantity, why we need to measure it, how can we get it measured, some of the difficulties in doing that, and talk a little bit about the instrument that we've been developing over the past several years. And then I'll talk about how I recently used that instrument to try to get at sort of a 30,000 foot view of self-titration behavior, population level self-titration behavior. Okay, so why should we measure cannabis quantity? Well, John Hopkins made this point, has published these data a few years ago, just basically pointing out like we're at a stage now where daily cannabis consumption in the United States has surpassed daily alcohol consumption. So there are a lot of near daily cannabis consumers in the United States now. And there's other papers showing that basically the probability of being diagnosed with CUD, cannabis use disorder, among daily consumers is going down, right? So we have daily use going up, cannabis use disorder among that group going down. What's going on? Well, the implications of that are frequency of use, right? Saying you're a high frequency user, that's becoming less useful as a predictor of problems, right? So we need ways of differentiating between daily cannabis consumers who have problems and don't have problems, right? Yes, so we need ways of differentiating high versus low risk consumption among daily consumers. And I think one way to do that is with quantity of use. Just to give you an example, you try to think about someone like person A, maybe they take a couple hits before they go to bed, right? But that's every day versus someone who, like Meg was talking about, they're using all day, every day, right from the morning. Those are both daily consumers, right? But very different risk profiles, I would say. But we really don't have a good way of differentiating quantity-based differences in risk. And so I've been spending several years trying to measure cannabis quantity in epidemiological surveys, and it's very tricky. One of the main reasons is just all the different methods of administration and product types that are out there now. Legalization has really just that's what America does. You throw capitalism behind it and just blows up. And so there's like a zillion kinds of, products, and it's very tricky to try to get, measure, or is it even worth it to measure all of these? The other thing that had been still sort of driving me crazy is like okay, we want to measure cannabis quantity, but what unit do we use? In the past, people, would use things like, well, the number of joints. It's like, well, I don't know, man. We've got vapes now, not edibles. Should we really be doing that? And like, how many grams are in a joint and that kind of thing? And then you think, well, okay, let's do hits. But then you run into how many grams are in a hits, and so it's a whole. There's that, I don't know who said it, it's that saying, it's like there's no solutions, only trade-offs. That's the the unit, right? So when you're trying to say what unit, you pick your poison. And then there's potency, right? So there's not only the unit of how much of the material you're consuming, but how strong is it? And the key foundational point is, right, delta 9 THC is what we know drives, I've read a lot of Meg's papers on these kinds of reviews on these sorts of things about it's the primary reinforcer, right? It's what drives biopsychosocial harm. So that's the thing that we need to focus on, right? Is delta 9. We can argue about delta 8 and delta 10, all that, later if you want to. But these are data from Washington State from a few years ago, but it shows the point, which is just that the potency, the percent THC among products that are available to people varies widely, right? This isn't Woodstock with 5% THC bud now. You can go all the way up to 30% THC bud, down to 5%, and there's concentrates are even higher, right? So there's this whole range of potencies, and that raises an important question when you're talking about measurement, right? When you're talking about quantity measurement, which goes along the following lines of, okay, well, let's say we know you used a joint and we know you used 1 gram of flour. That still doesn't really tell us anything, right? Because it could be low potency flour, high potency flour. So you really need to get at the point here basically being like, it's not enough to just get grams, right? You need to know how strong the product is. And then the combination of the two, the amount, grams or hits, and the potency, the percent THC, those two combined create what I think is what we should consider quantity or exposure, right, to cannabis. So now I'm going to go through a little bit about, hopefully I'm not going too fast. I'm trying to, Alan will kill me if I don't stay within 25 minutes. So I'm going to give you a high level view of the instrument that we've been working on over the past several years that we're calling the Cannabis Exposure Index, to try and measure all these different dimensions. So the idea is, okay, let's create some kind of, we want an epidemiological survey-based measure that can get at the core domains of cannabis use patterns and consumptions, that allows us to try to differentiate low versus high risk, and do so in a way where it's not so overly complicated that no one understands it and it can't, be used, because, I definitely go down that rabbit hole and have to come back. But you don't want to make it so simplistic that it doesn't address the things that you need to address, right? So we really tried to strike that balance. And we came up, the way we developed it is we measured the following domains, which is you still need to measure frequency, right? How frequently are you using cannabis? But we also measure in this instrument the types of products that you're using, the amount of the product that you're using, the potency of the product that you're using, and what methods of administration are using to consume those. So that's big picture on the domains that we cover. And I'll go through just some screenshots of how we do this in the survey, and happy to take questions about it, because I hopefully won't go through it kind of quickly and everyone's going to be like, wait, why'd you do that? And so we can come back to it. But big picture view, when we administer this instrument to people, one of the first things we do is we ask them, okay, what are you using? What products are you using? How are you using them, right? And based off of that, right, that's where the survey branches into asking different questions about each one of these particular kinds of methods and product types. We decided to go with a flexible unit approach where, so let's say you told us you use flour, then what we ask you is, okay, well, how do you want to report that? Do you want to report in hits or do you want to report in grams, right? And that's important because, if someone uses just at night and they say, well, I take 2 hits, they can't tell you the number of grams that is. It was 0.127 grams, and no one's going to know that, right? But some people, if they use 1 gram of cannabis, they're not going to tell you, oh, that's like 70 hits or something like that, right? So you have to take that cognitive, I think, piece into account. And then we do the same thing for concentrates, and I can talk about the other methods of administration if you want to, but I'm just using flower and concentrate as kind of the exemplar methods and product types. That get cut? Oh no, that got cut off. So the next piece is we get at the amount, which is how much are you using? And the way that we do that, right, if you tell us you use hits or you tell us you use grams, that will branch and we'll ask about, okay, well, how many grams of flour to use in the morning, evening, night, that kind of thing. And then same thing for concentrates, right? And again, we do the same thing for all the other methods of administration and product types. Did this one get cut off? No. Okay. This one's the controversial one. Don't kill me. Okay. Basically what we do is we say, okay, you use flour. What's the potency of your flour? And yes, I know a lot of people don't know what their potency is and all that, and we can talk about that. But Alan and I just felt like, well, we got to take the first step and try something here, right? So, so we asked people, okay, take your best guess, that kind of thing. And if you don't know, that's okay. Just tell us you don't know. And we do that for all the different product types, right? And then what we do is we take, amount, right? What was the grams you used? What was the potency that you used of a particular product type? And then we do that for each product type that you have. When we synthesize all of that with a formula we came up with, that's hopefully not too overly complicated, to get at milligrams of THC per using day. And that's what I think we should think of as quantity, right? Quantity is not grams, right? Quantity is how much of the thing that's reinforcing, that drives biopsychosocial harms, how much of that thing did you consume? So milligrams of THC per using day is what we came up with. So I'm going to show you some data now, and rather than go through all the specific sample sizes and everything, I just want to give you a big picture view of how we get the data and what the demographics look like. Over the past several years, we've done many iterations of this survey and developing it, and we've gotten about 30,000, survey responses, using that this social media recruitment technique that we've developed over time. And lots of biases with the way we sample data, and we can talk about that if you'd like to. But in general, when I show you the data that I'm about to show you, these are the general demographics. And the key point is that at least half of the data come from samples of, the samples are half like daily consumers. So it's a very heavy, frequently consuming sample for all the data I'm going to show you. Okay, so what are the insights that we can gain using this instrument? Well, the first main thing that we wanted to explore with this instrument was the relationship between milligrams of THC quantity and the use disorder, right? The probability of use disorder, the severity of use disorder, the number of criteria that you endorse, that kind of thing. And what we consistently find is this pattern, right? This sort of asymptotic diminishing returns, plateauing type relationship, again, on a population scale, where at by our estimates, low milligrams of THC, there's this increase up to about 100, 200-ish, then it levels off, which I think makes sense, right? If you go from 1 beer a day to 6 beers a day, that's, a big change in your risk profile. But if you go from 15 beers a day to 20 beers a day, you're already, at your, use disorder level. So that made sense. But then, so we see here with this, okay, there's a relationship between milligrams and risk. But then I started thinking a little bit more, and hopefully this is more related to the behavioral pharmacology piece of it, which is, okay, more milligrams of THC means more harm, but there's a subtlety there, which is, does that mean that more potent products means more harm? And this is a big argument right now among epidemiologists and economists and people looking at effects of legalization, right? And that brings me to this concept of self-titration, which I think, we touched on briefly earlier. the potency of products, right, has been increasing steadily for a long time. These are confiscated sample data from the DEA just showing potency's been going up, right, of products. And like I alluded to earlier, right, there's all these new products out there that are highly potent, right? And one of the questions that comes up is, well, if it's more potent, then we're going to have more people are going to have more problems. But then other arguments in the literature, no. Just because it's a more potent product, that doesn't mean they're going to consume more of it. They'll titrate down the amounts that they consume to achieve the same level of intoxication, right? So that's still an argument, maybe not among behavioral pharmacologists, but among the economists and epidemiologists, people are still duking that out a little bit. So what I wanted to do is use the CEI data sets that I collected to explore this issue of, well, what about just the potency of the products? How does that relate to the amounts that they report on a population level scale? And the hypothesis, right, it's just that as percent THC goes up, we should see the amount that people report consuming go down. All right, chug your coffee. Pay attention here. Oh no, how did I get? Okay. I did 4 kinds of analyses, okay? The first one is within subject, between product, which is, okay, let's take all the people who reported using flower, right, which is a lower potency product, and concentrate, which is a higher potency product. All the people who use both and say, okay, well, how many hits or grams did you take of the flower, the lower, and how many hits or grams did you take of the concentrate, the higher one, right? And compare those amounts. So that's within subject, between product. Then I did then to look at it at a different angle, I did between subject, between product, which is, let's take all the people who said they only use flower, right? The lower potency product, and ask them how many hits or grams do you use? And then let's take all the people who only use concentrate, how many hits, how many grams you use, compare those two, right? Then the other way I did it was between subject, within product, which is, let's take the people who said they use 10% THC flower, ask them how many hits, grams, and then let's compare them to the people who said I use 30% THC flower, right? And compare hits and, right? So the key thing is this between product kind of analysis, right? That's sort of a different way of thinking about it, I think. And then this will become clear why I did this after I did post hoc selection bias testing to see who are the types of people buying high THC versions of products, and you'll see why I did that analysis in a second. So these are the results from the within subject, between product. Y-axis is just the studies, right? Different studies, different data sets. X-axis is, again, I used both products, flower and concentrate. Let's take the amount of flower I used, the amount of concentrate I used, subtract the two for just me. You do that for everyone in the sample and then take the median value of those differences across the entire distribution, right? And for every single data set, every time we do it, you know, consistently on, well, I don't say on average, on median, that individuals who use both types of products report taking more hits of flower than of concentrate. And it's this, I find the same thing for grams, right? I use more grams of flower than I do of concentrate. The NA is because we only did hits of concentrate in the first study and decided, let's not do that. Let's see if we need grams for concentrate as well. So then we did, these are the between subject, between product results. Again, this is flower only people versus concentrate only people. What's the median number of hits in the flower only people? What's the median number of hits in the concentrate only people? Compare the two. And same thing. I mean, some of them were not statistically significant, but the trend for all of them is, in general, flower only consumers consume more larger amounts than concentrate only consumers. Not necessarily milligrams of THC, right? Not necessarily levels of the you know, total intoxicant that they consume, just the amounts of the product that they consume. Same thing for grams, right? So again, people flower-only consumers more grams than concentrate-only consumers. This one was the weird one. Okay, this one I had to think about for a while, and I'm going to show you. These are I tried to visualize this in a way that's sort of representative of the dynamics that are going on across all the different data sets, but it's the same phenomenon that happened over and over and over again, which is if you just look at flower, right, the green, the green products, what you see is that the amounts that people report is positively correlated with the percent THC that they report, which is antithetical. It's the opposite of the self-titration hypothesis, right? It's like, wait a minute, it's a higher potency and you use more. That doesn't make any sense, right? But I saw this over and over and over again, right? So if you take just the top graph, right, is all the people who, in one study who you reported less than 20% THC flower, what's their median hits? Next group is 20 to 24% THC flower, 20 to 25%. And you just see this stepwise increase in the median number of hits and of grams in these groups. And you see the same thing for concentrates, maybe not at the high end, but I saw this over and over and over again. And that's why I did this post hoc selection bias effect. I said, wait a minute, who are these people that are using the high potency products? So what I did is said, okay, what's the relationship between how frequently you use cannabis and the percent THC that you told me you use in the survey? And across all the studies, we see a positive relationship. So people who use more frequently, right, can report higher percent THC, the products that they use are higher percent THC. I should have done age onset a different way, but the age onset data also support the same concept, which is if you started using cannabis at a younger age, you report using higher percent THC cannabis. And I think this is indicative of tolerance. I didn't measure tolerance directly, but the more severe people, right, the ones with lower age onset and more frequent use are the ones who are reporting the higher percent THC products. And so to try to understand all the dynamics and explain these selection effects and the between and the within and all that stuff, I simulated some data to really try to visualize what's going on in all of this. And here's the basic concept of what I think is happening in epidemiological data, right? And why there's conflicting arguments about the presence of self-titration in these data. So it's kind of cool. It's a Simpson's paradox. Like you don't see that, they teach you about that in grad school, but you never really see it out in the wild. And I think I actually found it. So if you look at the flower, the simulated flower data, right? If you just took the average of that group, right? And the amount, you say, okay, those are the flower data, you have the higher amounts, and you take the average of the concentrate and you compare those two, you're going to find evidence in support of titration, right? The lower potency product is consumed in greater amounts than the higher potency product. But if you don't collapse, right, across products and you just look within product, right, you're going to see a positive relationship that I think is induced by these selection effects that I talked about, right? The people who have higher tolerance, more frequent use, earlier age of onset are going to gravitate towards the higher potency version of a given product type, right? So, if Kelly's low, low tolerance, he's going to go for the 10% THC flower. I have high tolerance, I'm going to go for the 30% THC flower. And that creates this positive correlation that people are seeing that are thinking, no, there's no self-titration because look at this, right? And so I think what we have to think about it is like something like your tolerance level, you stratify it by, tolerance, you have a y-intercept for different strata, right? And then once you've pulled out that selection effect, then you can start looking at these kinds of data and not worry about it. So, all right, just on time. So key takeaways here. So let's think of, let's try to think of quantity. We're talking about, Dustin was talking about terminology. Let's try to think about, I think we should think about quantity of cannabis as milligrams of THC, right? That's the clinically relevant, behaviorally relevant thing that people are consuming. But to do that, you got to measure the amount, grams, hits, and you have to measure potency. So those are really important for if you want to develop these kinds of surveys. And if you measure, if you do drill down and try and get at methods and try and get at product types and potencies, you can get some mileage out of those kinds of measures. Hopefully, what we're seeing, right, is milligrams is related to CUD, and you can clarify cool, interesting dynamics like the self-titration stuff that hopefully clears up the literature and people stop arguing about whether, what's going on. And so, yeah, I think you can do lots of interesting stuff with these kinds of data, lots of limitations, online convenience sample, and, who knows if people actually know their potency on their product and all that type of stuff. But yeah, so I just want to say thank you to Steve. Thank you for, to this really great conference. And thank you so much for having me and adopting me as the adopted epidemiologist child in the behavioral pharmacologies. And so, yeah, thank you very much.
All right, we got plenty of time for questions. If the presenters from this session maybe want to come up front so people can see you and ask questions.
Thank you.
Awesome session. And first, thanks to the wisdom of Steve for inviting you, because behavioral pharmacology, the most fundamental variables after the drug type is dose and pattern. And life is a lot more complicated than we were doing the cannabis studies and, when it was really easy. What a mess. So you're bringing order to it. Thank you. Dustin, your work is just fascinating. When Roland was having us look at all of the different drugs, how they affect smoking, there was something really interesting. All the strong euphoriants, alcohol, cocaine, amphetamine, opioids, pentobarbital, robustly increase smoking. Because Roland wanted to find out if it was a cookies and milk hypothesis. He said, they just go well together, but is there pharmacology? Cannabis was really weird. It was just a very weak effect. And so it's kind of a conundrum figuring this out. And so I'd love your comments. And Meg, getting into the therapeutic issues, another conundrum. And I urge everybody to look at the Department of Health and Human Services CAMU and 8-factor report in August and July 2023. If you can't find them online, they're kind of buried. It's 250 pages. But it was led by the Assistant Secretary of Health, Rachel Levine, and the Chief Medical Officer, and got all the agency involved. Question 1, is marijuana commonly accepted for medical use? The law says if you're not commonly accepted for medical use, you have to be in Schedule 1. So they concluded it's commonly accepted for medical use. 40,000 physicians approved across the nation to prescribe, 30 states allow it, et cetera, lots of self-reports, even though none of it met criteria by FDA standard for approval. So it's a fascinating thing how they did it. And that's how they got to say marijuana could be rescheduled and taken out of out of 1. And then where would it go? And then read their 8-factor analysis, and they said it's 3. So this is I was just bubbling over with thoughts as all 3 of you are talking. But I urge all of you to look at that. It's fascinating, well done document.
Thank you.
Well, I likewise was bubbling over with excitement from all of your talks. Unfortunately, I tried to write in my hand all the questions I had for you and then ran out of hand space and ink. So I'm gonna have to follow up afterwards if I could, and I'll just get to what I can get to. So I run the Vermont confiscated vape collection, or my we collect vapes from all 13 counties, can't get Essex County because nobody lives there. But we get them from all these different counties. I don't have a grant for THC, but as you must know, staff can't tell a THC pen from a vape pen, so I get a bunch of THC vapes included in that collection. I'm doing nothing with that data. There's and part of what I wanted to mention was that we see dual THC nicotine vapes. And I know you said that these 300 that you didn't want to go into, but I'm curious whether you broke down, looked at so in other words, there's two different types, as you mentioned, you can do it sequentially, you can do it at the same time. Some of the tanks have got both in the same tank. Some of them, they've got two tanks, and I don't know, we haven't opened them up, so I don't know whether they're mixing them on the way in, or if you just do one or the other. At any rate, so I'm curious about whether you have broken down the because toxicologically there's all kinds of questions. So
Yeah. So I would highly recommend contacting Danielle Smith and Mache Gonowitz at Roswell Park. That was the study that I was talking about. They have, I visited their campus in March, and they have they do the same thing you do with confiscated vapes in New York. I have seen the Elf THC, the Spliff Boy, I think, which is one of them. It's 2 tanks, and then there's a switch where you can have nicotine only, cannabis only, or whatever it is. I don't even know what it is in there, honestly, and nicotine cannabis hybrid. But if you need help, if you need resources, I think they probably have the resources and might be willing to collaborate. You come up and see me. We can
great.
talk more about that. Because I think it would be interesting to start breaking this down into multi-state, regional differences and availability of these products.
Yeah, because the national surveys, at least for nicotine, we found have no bearing on what's popular within our state, zero. So that's one of the reasons why we have to do the actual collection ourselves.
Yeah, absolutely. I think it's highly valuable that we do all the testing that we can on anything that's collected in the real world. So I appreciate you.
Well, in fact, I would be glad to offload these.
I bet you would.
So the second question, let's see, on the concentrations, well, that's actually related to some of these vapes. It's related, and actually, what I'm trying to say is, succinctly, is that they brag about concentrations that are insanely high, and then we realized that they were using tricky language, and really what they were saying was it was 99% cannabis product, but they put high potency right next to that, and so 99% cannabis product doesn't mean anything in terms of the concentration of THC. It's just they're trying to say something that sounds so outlandish that, wow, this is the really, but we would love to figure out what's the actual concentration in there. And again, but I have no grant money for that because it's all tobacco currently. So we'd be glad to provide these to anybody else who might be interested in, finding out what's actually in there. And then the last, I'm sorry, I don't know your name, sir. So just a note, at another presentation, they were talking about gamblers and how those with gambling use disorder are really drawn. You could say they have a tolerance for risk, perhaps, and they are most attracted to not the $1 ticket or the $5 ticket, but the $50 ticket. And it just struck me that Simpsons
selection effects.
Yeah. And so they're getting the pleasure. There's pleasure that they're getting from fantasizing about maybe, and also the risk, that adrenaline risk. And then also they'll go back and they'll buy another $50 ticket when they've lost so much money. They've lost their families. They've lost so much and they can't stop. So I just wondered, it just seemed like there was an overlap there with.
I mean, it sounds like, I'm not an expert in gambling at all, but yeah, it sounds like just the broad concept is just the severity of the pathology, degree of pathology of some kind of disorder, right? You want to stratify along that severity and keep that in mind when you're looking at your data so that, because, people at one end of the spectrum are going to gravitate towards very different things than people at the other end of the spectrum. And that can, if you do observational data like I do, you don't get the luxury of like randomization to wash out all those effects. So you got to account, for that kind of thing. So yeah, and it's an interesting connection.
Thank you very much.
Okay, great. Xiaozhong Wan from University of Buffalo. So I have two questions. First one is for Jack. So I'm also an epidemiologist myself. So I appreciate your very nice interpretation of the data together using that graph to explain the Simpson paradox.
Thank you.
Just clarification, your 4 studies are all cross-sectional studies, right?
Yes, all
Okay.
cross-sectional.
We know, that's kind of limitation in terms like the association is not causality here and also is happening at the same time. So my question is like for next step, if you want to prove the titration idea, do you want to do some further experiment studies to verify your hypothesis? Like for example, you bring the same people, then they maybe start with a high potency, then you decrease the potency of the product to see how they change that product. So then you can look at them perspectives.
That's a really cool question. I mean, one of my fantasies is to get one of those buses that you can go to people's houses and you have the lab in the bus and you can do all the titration. But I think people here, have already answered. Like Meg is probably a better person to ask that question to than I have. I think they know how to do the self-titration work. I don't know how to do it, but I think
Collaboration.
yeah.
Just along the titration question, Kent Hutchinson has that vehicle. So he
Yeah.
goes to cannabis users' homes in Colorado, and they're using products, usually leaf, like 20 to 30% THC. And in the lab, I'm using 5 to 10%. But when we look at our plasma THC levels, so he has them use as much as they want. I kind of dictate what my guys use, but we both get the same plasma levels. So even though I'm using very low potency product, we have the sweet spot of 100 nanograms per ml of THC in plasma, when he just naturalistically is looking at very high potency. So there it looks like titration. My question has always been, what happens when these very heavy, these high potency products, they must develop tolerance. I'm thinking if they're using it repeatedly, they
Yeah.
would up their use over
Yeah.
time. But it always struck me that 100 nanograms per ml was the sweet spot that everyone liked THC's effects. So they did titrate in that example. But
Yeah. I think the point I just wanted to make is with these data was just, if we're going to stop, you got to look between product and within product to really understand what's going on with the data. But I'd love to do a few, a follow-up study where we actually do administration and all that stuff, but I don't have the patience for
call me.
the paperwork is probably insane.
It's
Yeah.
terrible.
Yeah, I think that's
It's horrible.
to prove that is very important for the policy and regulation.
Yeah.
Because your data, the graph show you the increase of potency over the years. Definitely is a kind of concern, but we are not sure, how that may impact the health risk.
Yeah, the risk, exactly. And I think, I don't know, right now, my current thinking about it is, and everyone's, open to feedback on it, but my current thinking on it is, yeah, people do, think about what's the volume of liquor that you drink versus the volume of beer that you drink, right? I mean, so, but then you have to there's like, different tolerance levels, right? If you stratify by that. So you're going to see the same dynamic, but across different strata of tolerance. That's kind of how I'm thinking about it. And I think that's important for understanding.
Yeah.
Like if you want to model population T exposure and how that changes risk at public health, yeah, you keep that in mind.
If you had a chance to do that in the future, I would suggest you also measure the health risk, like any disease,
Yeah.
social impact as well, the family. So that would definitely provide a very solid evidence to
Thank you. Yeah,
policymakers
that's a
whether we
good
need to do
idea.
something with the potency.
That's a really good idea. Thank
great.
you.
Yeah, my second question is for Dr. Lee. Thanks for sharing so much data there. One thing I feel a little bit disappointed is about the differences between the simultaneous cessation versus the sequential cessation. So at the beginning, I thought that would give, that's a good idea, right? We test that, figure out that has big implication for treatment. So my question is about the sequential part. I didn't read that study, but did they actually put one like tobacco first or marijuana quitting first, or did that participant to choose?
No, I think you're asking a really important question. We had the cannabis treatment first, no matter what, and tobacco was either simultaneous or sequential. You're asking a really important question, though, which is if you did it opposite and have tobacco cessation first, followed by cannabis, what would be the outcome? I don't know the answer to that, but I that's fascinating. I think for us that question was mostly around, we were thinking back to treatment acceptability and thinking about, AA models and other treatment approaches where simultaneous cessation of two substances, including tobacco, really it was like thought that it would scare people off. So we wanted to provide, a kind of a methodological approach that would test out, whether people would be less, less responsive to treatment if it was simultaneous. We didn't find that. We found that everyone that was in the simultaneous group was interested and participated in some part of the treatment. Outcomes weren't so great. Participation was great, outcomes not so much. That's a similar story with tobacco treatment in general, but yeah, I think you're asking a really important question.
Yeah, great. So I just want to follow up of that because we have a small pilot study to test exactly simultaneous versus sequential strategies for dual users of cigarette and e-cigarettes. Because as you said, some people may feel like a bigger lift up if you ask them to quit simultaneously. They want to have something to turn to, right? So then we say, then we can try sequentially. Then for sequentially, we do a maternal child health, so it's pregnant participants. In this case, we kind of debating between should we ask them to quitting cigarette first or e-cigarettes? Because the background is that so far we see that people who use exclusive e-cigarettes tend to have a little bit better birth outcomes than the mothers who use combustible cigarettes exclusive. So that's why we say, if we think about the health outcomes, maybe we should prioritize combustible cigarettes first. If they can quit that, we can get a lot of benefits in terms of the birth outcomes. However, if you look at the observational studies showing like people who use e-cigarettes exclusively, they have a high cessation rate during pregnancy than mothers who use combustible cigarettes exclusively. It's about 80% versus 50%. So we think, if you think about no-hanging fruit, maybe have them to start with something easy to quit first, and then build the self-confidence, and then they can, if they achieve that first, then we can move on to next targets. But in this terms, the birth health benefits versus the difficulty of quitting, we kind of debating, which one we should choose. What do you think?
I think that the person to ask is standing right back in the back of the room. Yeah. I mean, in harm reduction, it depends on the approach. Like a harm reduction approach, I would say combustible, right? Like we're trying to go after and immediately reduce the most harmful product that we know of. Given yesterday's conversations, notwithstanding. But yeah, I mean, I think there are experts that are in this room that have done, prenatal cessation work for years that I think would be really helpful in kind of developing a clinical approach to that.
Thank you so much.
Sorry, Sarah.
Thanks for the fascinating talks, everybody. I guess this question is mostly for Jake. I was really struck by the labor of love to be comprehensive in asking people about their cannabis use, all those different forms. And I might have missed it. Was it all inhaled?
The data that I showed was all inhaled, but we do get at the primary other ones that we get at are edibles, tinctures, and capsules. So we do get at those other methods of administration. But the way that we quantify exposure quantity is different because it's already geared, like edibles, I mean, it's already in milligrams, right? That kind of thing. So, but the other, we do smoking buds, vaping buds, open concentrates like dabbing, and then like cartridge concentrates. And then I can't remember if there's one more, but yeah, so it's mostly inhaled, but we do get a lot of the oral products, but we don't do like the skin products or all that kind of stuff because like if you do that, man, the survey just blows up and like it's just crazy. So we try to find that kind of like, otherwise you can't, execute it. So.
Yeah, thank you.
Yeah.
I just came off of a clinical year where I was like treating people for all different types of substance use disorders, and I was going insane. Like,
Yeah.
it was like, okay, so I use like this vape, but then I also bought this like THC patch, and I'm like, THC, is that a sticker? Like,
Yeah.
what?
And it gets one quick thing too, is like, the way I look at it, it's like, oh yeah, we got estimates of milligrams of THC, and some we calculate that they have 100 milligrams. Like, do they really have 100 milligrams? No. The idea is just they have some, we do our best to get some estimate so that we know that like, okay, the person where we calculate they got around 100 milligrams with some margin of error, they're definitely lower than the person who is estimating 300, but it is exactly 300. I know. So I think of it more like rank order rather than, absolute values or anything like that, because you're right. We're going to miss. It's just, there's so many levels of error that come into the process in terms of people's cognitive ability to remember and estimate, and they forgot that they also use a patch and all that stuff. So, but yeah, it's finding that balance is very hard.
Well, thank you. I really appreciate your going into it and making some trade-offs and taking a stab at it and trying to bring some order to it.
Thank you very much. Yeah.
Holy smokes. I thought the work I do is hard. You guys are having to face issues of dose and route of administration and oh my gosh. But one thing that I didn't hear a lot about, and I think it's a question for all of the speakers, is the role of the different types of cannabis plants and because there are hundreds of cannabis substances in each of the plants. Can you speak to the issue of abuse potential, the withdrawal phenomenon across I know it's like hard to do that kind of research because you can't get an IND from the FDA to study it, but is there anybody who's doing that in a naturalistic setting, comparing the different species of?
I feel like Tori and Ryan.
Yeah. Yeah, Hopkins, they're doing a lot of the constituents, but one of the things I didn't have time to mention was with Caroline's study. She did test a high CBD plant looking at the analgesic and, the tolerance effects, and it was very much muted. So the THC content, so CBD is showing a very different profile of effects for these indications. So I think the constituent question has been, we're getting a lot more into it, not just of cannabinoids, but all, flavonoids and the other components of that cannabis plant. So it's very complicated. The plant is a complicated beast, but, we're gleaning more. I still hang my hat on Delta-9 THC.
Yeah.
That's the primary, that's the one we can get, such lawful data on and so forth. But, Delta-8 is right there behind. But, the interesting thing about Delta 8 is the sneaky stepchild of the farm bill. So, you know, in states where cannabis is legal, there's not a lot of Delta 8. It's this workaround where you can legally sell Delta 8, and Canada doesn't have any Delta 8 issues. So, you know, Delta 9 is still the one to hang your hat on, I think.
Yeah. Yeah, and Delta 8's unregulated, so there's a good chance that, you know, there's a lot of Delta 9 in it anyway. And then, you know, thinking about the plant difference, like indica versus sativa, if that was, you know, the question too. I think there's an upcoming study. I think Austin Zamarip was partnering with folks at the Bloomberg School of Public Health to look at an expectancy study, looking at indica versus sativa. But I mean, at the end of the day, I agree with Meg. It goes back to the Delta 9, as far as we know.
Yeah, and indica sativa is kind of a misnomer anyway,
Yeah,
right? It's not a
yeah.
real phenomenon, although cannabis users hate to hear that.
Right. Which is the purpose of the expectancy study, I think.
Exactly, yeah.
Yeah, I think that I've been trying to make that point though, like when I do talks for like lay public, is cannabis is unique because it's not really one drug, right? It's like it's like, I think they've identified over, it's like 150 cannabinoid compounds and all that. So it's unique in that sense. I think it's also, the other tricky part about it is that point I've been trying to make is it's one of, if not the only drug that I'm aware of that is simultaneously regulated legally as both a medical and a recreational product, right? It's sort of in this, it's like regulated in both ways, and that creates a lot of other, in addition to it not being one compound, it's treated in two different regulatory capacities. That makes it even more complicated.
All right, I appreciate all of our speakers in this session. I thought it was a really great session. We are coming up on lunch. I would encourage everyone, we have a lunch and learn session at 12:10. So if you want to grab some lunch, come back in here. There is a session at 12:10, topic being incentives for smoking cessation, the 2025 Cochrane review results. So come on back in a couple of minutes.